Hello, this is Jerome Sabate, and I will be discussing about the Binocular Indirect Ophthalmoscope or BIO. Let's have a quick overview of the BIO. A binocular indirect ophthalmoscope is a head-worn optical instrument used to perform a fundus examination similar to a direct ophthalmoscope. But unlike a direct ophthalmoscope, it consists of a headband, lenses, and a light source, providing a wide stereoscopic field of view with 2 to 5 times magnification. Now, this allows examiners to see the peripheral retina, making BIOs valuable for diagnosing and treating retinal tears, holes, and detachments. Now, there are a few important notes. In using this instrument, the room should be dark for optimal viewing, and the patient's eyes are dilated for better viewing of the fundus. The patient can either be seated or lie prone with their head at hip level. It is less frequently used compared to other methods, like the direct ophthalmoscopes. An inverted real image is produced in space by a convex lens. Now, BIOs require the use of special lenses called condensing lenses. The condensing lens is held near the patient's eye to gather light from the retina, creating a clear, magnified, and inverted image. The lens power affects the viewing distance magnification and a field of view, with higher power lenses offering a more magnification and a wider field of view. Common lens power range from positive 14 diopters to positive 30 diopters, with the positive 20 diopter lens being standard for general examination, providing 3 times magnification and a 45-degree angle field of view. The positive 30 diopter lens offers 2 times magnification and a 65-degree field of view. Now, higher powered lenses are often used for examining small children and or patients with small pupils. Now, for the content, I'll be discussing the brief history of ophthalmoscopes, types of ophthalmoscopes, as well as the types of indirect ophthalmoscopes, the optics, the parts, functions, and how to use the BAO, and the proper maintenance of the instrument. Now, let's trace back the history of how the BAO was introduced and developed. Ophthalmoscopy started in 1851 when Hermann von Helmholtz came to understand how light enters and exits the eye, which led him to create an instrument to view the fundus or back of the eye. A year later, Christian George Theodor Rouet modified Helmholtz's design by incorporating a concave focusing mirror, and thereby introduced indirect ophthalmoscopy to allow for a stereoscopic and wider view of the fundus. Later, in 1945, Dr. Charles Louis Schepens further refined on the original design by adding a second lens for the other eye, resulting in a larger field of view and inverted view of the fundus, which facilitates more comprehensive examinations. Types of ophthalmoscopes. In ophthalmoscopes, there are two types: direct and indirect ophthalmoscope. The direct ophthalmoscope provides a narrower field of view, offering a more focused and detailed examination of the retina. Its higher magnification compared to the indirect ophthalmoscopes makes it ideal for examining small structures like blood vessels, nerve fibers, and lesions. The image produced by the direct ophthalmoscope is direct and virtual, allowing for a true representation of the structures seen in the eye. While it offers advantages such as detailed views and higher magnification, the direct ophthalmoscope has limitations. Its narrow field of view, which can make it challenging to examine the entire fundus, and requires more patient cooperation to maintain a still eye during the examination. Indirect ophthalmoscope. It provides a wider view of the fundus, including the peripheral areas, but offers a lower magnification compared to the direct ophthalmoscope due to its panoramic view. The image produced is inverted and real. While it allows for a broader assessment of the fundus, including peripheral areas, it requires a condensing lens to be held near the patient's eye, which can be challenging. Now, under indirect ophthalmoscope, there are two types: monocular indirect ophthalmoscope, or MIO, and binocular indirect ophthalmoscope, or BIO. Here's a photo of the instruments mentioned. The monocular indirect ophthalmoscope, or MIO, offering a single eye view which can make assessing the retina's depth and 3D structure more difficult. Without binocular vision, determining the relative positions of structures within the eye can be challenging. Monocular ophthalmoscopes are typically simpler, less expensive, and handheld, making them more portable. While dilation can improve visualization, it's often unnecessary, especially for routine examinations. Binocular indirect ophthalmoscope, or BIO. It offers a stereoscopic view of the fundus, providing a more accurate depth perception and understanding of retinal structures. This binocular vision is valuable for diagnosing and managing conditions like retinal detachments and vitreous hemorrhages. While BIOs are more complex and expensive than monocular ophthalmoscopes, their head-mounted design and ability to provide a stable, hands-free viewing experience make them a valuable tool. Pupil dilation is typically necessary for optimal visualization with a BIO. Optics and schematics. Now, knowing the optics and schematics of this instrument will help us understand how the indirect ophthalmoscope works. Now, observe the ray diagram on the right. The binocular indirect ophthalmoscope, or BIO, utilizes a halogen lamp or LED as its light source. A condensing lens focuses the light onto the patient's pupil, while filters can be used to modify the light's color or intensity. The observation system consists of two eyepieces that can be adjusted to match the examiner's interpupillary distance, or IPD. A high-powered aspheric lens, typically positive 20 dipplers, is positioned at its focal length from the patient's eye, focusing the light on the retina and magnifying or inverting the retinal image to create a real image. The BIO's optic system employs mirrors or prisms to split the light beam into two separate beams, enabling stereoscopic viewing. Now again, to simplify further, the light source emits light which is then focused on the patient's pupil by a condensing lens. This light enters the eye and is directed towards the retina where it is reflected back. The reflected light passes through the condensing lens once again, magnifying the image. The BIO's internal lens system further magnifies and inverts the image, projecting it into the examiner's retinas for detailed examination of the fundus. Parts and functions. Let's get acquainted with the parts and functions of the BIO. Now for its functions. The headband size adjustment knob is used to tighten or loosen the band at the top. The headband height adjustment knob is used to tighten or loosen the band around the head. The band tension knob is used to tighten or loosen the part of the band where you can lift up or down. The brightness control knob adjusts the intensity of the light beam. The angle knob adjusts the angle of the light beam. The filter knob changes the filters. The aperture selection lever changes the apertures. The mirror angle control changes the angle of the mirror to redirect the light beam. The front window where the light will come out, and lastly the eyepiece where the examiner will look through. The BAO light filters. No filter or white filter is used for natural viewing and initial assessment. The yellow filter reduces light and is comfortable for patients. Red free filter or green filter improves contrast and easy viewing of the blood vessels and lesions. The blue filter or cobalt blue filter, it highlights interior structures and is used after the fluorescein angiography. How to use the BAO in ocular examinations. The equipment includes the binocular indirect ophthalmoscope with power supply, a positive 20 diopter handheld condensing lens, and dilating agents or mydriatic drugs. Preparing the patient. Dilate the patient's eyes 30 minutes before the exam. Position the patient. Recline them so they're facing upward. Their face should be slightly below yours, and in any case, the patient may be examined in a sitting position. Preparing the BIO and condensing lens. Put on the BIO, adjust the headbands for a comfortable fit, position the oculars close to your eyes, and adjust the PD for appropriate binocular viewing. For this, you have to close one eye, hold your thumb out at arm's length, adjust the eyepiece until your thumb is centered. Now repeat with the other eye. And if adjusted correctly, you'll see your thumb clearly with both eyes open. Turn on the light. Set the intensity to medium. Adjust the light position to the upper half of your field of view. Now hold the condensing lens. Hold it in your dominant hand between your thumb and index finger. Convex side of this lens is facing the examiner. Tilt slightly to reduce reflections. Now note, you must keep the light, the lens, and the patient's pupil aligned to keep the retinal image in focus. Proper maintenance. Keep the instrument in its case when not in use. When storing the instrument, keep it in a clean, dry environment away from excessive heat, moisture, or direct sunlight. Make sure the on and off switch is fully turned off. A click sound will be heard before placing the instrument in its case. Recharge the batteries according to the manufacturer's recommendations. This ensures optimal performance and prevents unexpected power loss during use. Wipe the headband and the instrument surfaces with a cloth damped in mild disinfectant every day. Clean the condensing lens and viewing lens with a soft lint-free cloth damped with warm water and a mild cleaning solution. Regularly inspect the instrument for any signs of damage, such as cracks, loose screws, or worn cables. If you notice any damage, discontinue use and contact the manufacturer for repair or replacement. Now these are my sources, and that is all. Thank you.